Hello, this is Enrique Alvarez. I'm one of the neurologists at the Rocky Mountain MS Center at the University of Colorado. I've been there now 7 years, and today I'll be talking a little bit about giving an update on COVID and as it relates to multiple sclerosis. With that, let me start sharing my screen. So we've been doing a series of these over the last few weeks, but to kind of provide a little bit more background, I'm going to start just by talking a little bit about timeline and flattening the curve as it relates to COVID. A lot of news on this has been addressed and things, but to kind of provide a little bit of some of the numbers and modeling as it that have affected sort of how we've dealt with things here in Colorado. We'll talk a little bit about reopening. That's the phase we're starting to kind of slowly progress towards. And then additionally, we will be doing some talking about testing, and we'll talk a little bit about disease modifying therapies and sort of the experience in the world as it relates to this. So one of the things to think about is how much our world has changed in really no time. So if we recognize that in December 31st was the report of several cases of pneumonia that came to light out of Wuhan, China, we can see that it's impressive that we're in May and how much our lives have changed in that short period of time. They identified the virus in almost record time. So in January 7th, they identified the virus. This is the official name, SARS-CoV-2. It's the most related virus to SARS, which went through southern China as well. And we often refer to it as COVID or COVID-19, and for simplicity, we'll just be calling it COVID during this presentation. And these are coronaviruses. So coronaviruses are the viruses that we often refer to as the common cold, a little bit different from the influenza viruses that cause the seasonal flus. But we start moving along this timeline, and by January 11th, we hear about the first death occurring in China, and that by January 13th, we start to hear about the first cases starting to happen outside of China, particularly it happened in Thailand. And as the timeline starts to move, we start to hear about sort of the first clinical trials in the US with remdesivir, which is a treatment that was originally developed for Ebola. And that that recently, some of you may be aware of, was starting to get used and somewhat temporarily approved in the US by the FDA. Again, very recently, as of early last week. We had some difficulties initially with testing, and we'll talk a little bit about that, what that all entails and some of the issues that happened. But as we know, some of the testing initially was faulty. And then by March, we start to already looking at 100,000 cases, 4,000 deaths in over 100 countries. By April 2nd, we're starting to talk about 1 million confirmed cases. By April 10th, we start talking about 100,000 deaths globally from this. And these numbers, as you know, are already a little bit outdated as the cases have continued to increase. So there's been a lot of modeling that's happened. One of the main agencies that has been doing a lot of the modeling is out of the University of Washington. The IHME is a publicly available website, so you can go through and look at these models. They get updated every few days. And this was actually just updated about 2 days ago. And again, this recording, just for reference, is on May 7th. But, and these were actually new views. So to show a little bit of the infections, and these numbers particularly are specific to the state of Colorado. And what we can see is that the estimated infections started to occur a little bit before March 1st, end of February, with sort of a fairly rapid increase in number of cases. And it's predicted that the number of cases actually started to decrease in the community. As you can see, the line of daily tests did not match these numbers. So this is a little bit of an exercise in estimating and guesstimating the number of cases that are out there. As the number of tests ramped up, you can see that more and more patients were getting diagnosed. And then there was a little bit of a decrease. This is really when the ramp up of testing started to occur, and that was mid-April. And that was a huge benefit for us to be able to start screening patients during this time. And here in March and early April, it was not too uncommon to wait 10 days or longer sometimes to get some of this testing back, which made it very difficult. Because of all this testing, you can get sort of this increase of confirmed infections, but you can see that the number of confirmed infections really lags sort of what's estimated to have been the case of real infections out there. We can superimpose on this graph deaths, and these are not to the same scale, but you can see that there's a lag between sort of the number of infections and the number of deaths, and that these are pushed out approximately 2 to 3 weeks. This is helpful to realize that a lot of times if you're looking at deaths, that this is an indicator of something that really happened 2 to 3 weeks earlier, which is the estimated infections. But you can see that the curves really match up well with sort of these guesstimated number of infections as they occurred. And then we're starting to see maybe a little bit of a peak at the end here as things are starting to reopen, and we'll talk about that shortly. One of the most important reasons to use this modeling was to be able to understand the number of cases and whether or not we were going to be able to handle these cases. Again, this is modeling from just a few days ago, and the very critical important levels are the number of hospital beds that are available. In the state of Colorado, it's just under 5,000. And the number of ICU beds available, which is slightly over 500. When we look at the number of hospital beds that we thought we were going to need, you can see that we're staying way under this, and that our max peak was probably around 1,000 beds. And now we're in this phase where the number of cases is starting to come down. These other lines represent the number of ICU beds, and those ICU beds that were requiring intubators. As you know, there was concerns for shortages of intubators. And you can say, well, what was all the fuss about? We had a lot of extra capacity around this time. Although you did see that, about half of the ICU beds in the state of Colorado at one point were being used strictly for COVID patients. And that implied having to holding a lot of other surgeries to get pushed off so that we could handle these COVID cases. This doesn't look terrible, but this is what the initial models look like. This was some of the very early models that showed that the number of hospital beds in the state of Colorado that we were going to need was going to be way over that of 5,000 and what we could really handle. And that's what you saw happening in New York, where they started having to use the convention centers as hospitals, where they were starting to kind of think about needing to put 2 patients on one ventilator. And things like that. And so we can see that the number of ICU patients was over twice that of what we could safely handle. Again, these were kind of models, and thankfully we started taking measures to try and prevent that from happening. And some of that was social distancing. So as far as social distancing, one of the things that started to occur was being able to flatten out those curves, and that allowed us to start looking at this, at these cases and trying to prevent sort of that overpowering of the hospital. This slide shows kind of the opposite end, the stage we're at now, where we're starting to open up and kind of relaxing some of the social distancing rules. And this is the plan that these were bullet points that we would have to meet in order to be able to open up things again. And you can see this was a proposal from the CDC and President Trump, where we had to have a number of symptoms, cases, and hospitals meeting criteria before we really should be thinking about opening things up. On the symptom side, we needed to look at flu-like type symptoms, or at least COVID-like type symptoms decreasing for 2 weeks or 14 days. This is a little bit harder to track, so I'm not going to talk too much more about this because a lot of colds and flus can look like COVID, and it's hard to tell without having good testing. On the number of cases, we wanted to see a downward trajectory for 14 days in either documented cases or in positive and confirmed positive tests, so in either suspected or confirmed cases. And importantly, on the hospital side, we wanted to have the capacity at the hospital end to be able to treat all the patients without having to go into certain circumstances called crisis care, and basically emergency type rules for caring of patients in the hospital where maybe we can't provide ideal care as much. The part we'll talk about a little bit later is the testing. I think it becomes really important that we have testing, because without testing, we're making a lot of guesses as to who has COVID and who doesn't. And especially the emerging antibody testing, we wanted to have this available because it allows us to screen people in certain situations. It might help us with evaluating for convalescent plasma. And again, we'll talk a little bit about that later. But let's start looking at the number of cases. This is a graph showing the increased number of COVID positive cases in the state of Colorado. And you can see that these numbers are all over the place and very much jumpy. And some of this has to do with reporting of cases. This peak here had to do with adding patients that were suspected of COVID, related to patients who had later tested positive for COVID and had similar symptoms, and they were added in. Initially, they were only looking at confirmed positives. And so you can see that these bulks end up happening kind of gradually throughout this. You have effects of the weekends where sometimes the reporting isn't quite as ideal over the weekend, and they get reported on Monday and then maybe recorded on Tuesday. And so one way to deal with this is to do a moving average. If you look at a 3-day moving average of cases, and it helps smooth out these curves a little bit, it's possible to see that in March we had this increase in cases, and towards April, mid-April, we start to see a little bit of a decreasing number of cases. There was a small, again, increase in cases, more than likely attributed to this bulk of patients that were included from much prior that were not confirmed. So if you can skip that and kind of look at just this, what's impressive a little bit is that it hasn't really been until April 26th, 27th that we started to see this decrease in the number of cases. The important point is that we're starting to see this decrease. And remember, April 27th was when things in the state of Colorado started to open up. That, of course, got a little bit more delayed in certain communities, including Denver County and some of the other metro counties, where through May 8th, they still have some of the stay-at-home regulations and guidelines. So here we can see that a little bit better, just kind of that smoothing out of the curve. One of the concerns that we have is that in our hospital, at least in the UC health system, so this is including Poudre Valley, Memorial, and Denver, respectively, up in Fort Collins, Colorado Springs, and Aurora, is that the number of patients admitted to the hospital basically since beginning of April have been really stable. And some of this are patients that are sick and just kind of staying in the system. So this may be delayed as far as number of cases. And over the last few days, we're starting to see a little bit of a decrease. But again, this is not cutting off that much earlier from this, maybe from a week ago. So with having sort of a decrease in number of cases, one of the things that we started that I mentioned was this relaxing of social distancing. And we can see that as a state that the stay-at-home order was stopped on April 27th, or at least it expired, I should say. The non-essential businesses closed. Some of this started to get relaxed, but you still see that some of the other measures for social distancing were still and are still enforced. This is a little bit slowed again in some of the other counties, such as Denver and some of the other metro counties. But what we can see is that the change in mobility, so just you can look at numbers of a number of different ways to look at how people are distancing themselves, things such as how much gas are people using, what's the electricity use, how many cars are driving by certain points on roads. And looking at some of those measures, the state or using this modeling, this is actually again coming in from the University of Washington, that the social distancing kind of by mid-March started approaching 30%. And with the stay-at-home orders, according to this model, achieved somewhere between 55 to 60%. Some of the numbers from the state of Colorado suggest that this number may have been as high as 75%, which really allowed for that flattening of the curve that we discussed earlier. As we can see then, as they're relaxing and people getting tired of some of these measures, you can start seeing a little bit of gradual social relaxation that happens, and things are starting to kind of change again. This will probably kind of continue to come up as we relax things out a little bit more. But these are the kind of models that are being used for that and that allow us to evaluate when we can start to open things up. This is a little bit how the university is looking at opening up. So things started very slowly on Monday, April 27th. The main campus is located in Aurora, and we were able to start doing some of this stuff. I can tell you not much really happened that very first week. There was a lot of planning happening. And the first phase really involved trying to get some of the procedures and priority visits back in. And these were patients that needed surgeries that had been pushed off, that really could wait a little bit but couldn't wait too much longer, and the goal was to try and get back to no more than 30% of patient volumes compared to what we had before. The reality is that, for example, in neurology, we got up to maybe 10% of what we had before COVID, and then the idea is to not increase more than 10% per week after that. This is 2 weeks later, and I can tell you we're nowhere near 50% of our clinic volumes being sort of in face-to-face type encounters. At the university for neurology, we're maybe up to about 15%. And so really expect that over the next several months that most of the MS telehealth, most of the MS visits will be occurring via telehealth. Some of the new visits will probably be the priority because it's a little bit harder to evaluate somebody via telehealth. And so if you're meeting somebody for the first time, you're going to want to see them face to face. It's a little bit easier to review MRIs, patients bring in their records and things like that. And so we really want to emphasize, those visits as opposed to some of the return visits in clinic. One of the things I'll just bring it up as hints is that, if you can if you're doing a face-to-face visit, consider bringing your own mask if possible. There are some cloth masks that are starting to be dispensed at the hospital, but again, these are limited and in short supply. So if you have your own mask, please bring it. And then just the emphasis to bring in records, MRIs. We always emphasize this. Patients that have been around will know this, but especially if you're looking at coming and joining us, anything that you can think about trying to bring that in right away with you in those visits, that will help cut down on having to do follow-up visits to look at those MRIs and things like this. So make those visits much more efficient. And so always try to remember to bring those in. So let's talk a little bit about testing. The very first type of testing that occurred was this RT-PCR testing. I'm including this kind of complicated picture up here on the top to show probably the most important part of the whole test, and that is having to stick that swab deep inside the nose. If they don't stick it in there good, you're going to get a crappy sample. You're not going to get a lot of the virus. The virus infection starts here in the nose and then slowly migrates down, and there's very little in the nose. It's more in the sinuses areas and these a little bit deeper in. And so if you don't get a good swab, you're not going to be able to pick it up. The technique for picking up these viruses doesn't need a lot of the virus around to have a positive test. And so it becomes, again, I can't emphasize it enough, how important this first step test is. The next part, the RT, is just reverse transcriptase, and that has to do with just that the RNA itself is an RNA virus. There's RNA and DNA. Most cells have DNA, and then it becomes RNA, and then it goes to proteins. In this step, you have to do a conversion of RNA to DNA, which then gets amplified through the PCR reaction. And this can be amplified many fold over. And so very few copies will slowly be amplified through this reaction, and then you can become positive and you can pick it up with these machines that allow you to decide that a test is positive, or if you don't pick anything up, that the test is negative. But if you don't get a good sample, you're just not going to be able to amplify that DNA to be able to pick it up on these tests. So the important point for this as well is that this picks up the actual virus. If you've cleared the virus, the test will be negative. So if you had COVID and now are feeling better and your symptoms have resolved, this COVID testing will not pick it up at all. You have to be shedding the virus. And again, the sample has to be obtained really well. The important point for this is it's only been really over the last couple of weeks that we've had the capacity